Hi everyone, and welcome to our first module on labor and delivery. The definition of labor is uterine contractions during pregnancy plus cervical changes. There must be cervical changes present in order for it to be considered labor. We'll talk in more detail about the cervical changes associated with labor, but the cervix undergoes a process called effacement. It also dilates to a maximum dilation of about 10 centimeters. Many women during pregnancy experience what are known as Braxton Hicks contractions. These are uterine contractions not associated with cervical changes. Often these are not felt until the third trimester, although occasionally they can be felt or palpated on the abdomen as early as 18 weeks. They can often be seen when a woman is having a sonogram during early pregnancy. Besides being associated with no cervical changes, Braxton Hicks contractions are usually irregular and they don't become stronger or more frequent over time. When a woman in pregnancy presents with contractions, the initial evaluation is usually an ultrasound to check the health of the baby and also a cervix check to make sure the cervix is closed. But if the cervix is closed, then that indicates the woman is not in labor. Beyond the ultrasound and a cervix check, you can do further evaluation with a non-stress test, but if the non-stress test is reactive, usually no special treatment is required for women with Braxton Hicks contractions. They don't need observation in the hospital and they can be discharged home. Labor can be divided into stages. There is a first, second, and third stage, and then the first stage of labor is divided into a latent phase and an active phase. The latent first stage is from the onset of labor until the cervix is 4 to 6 centimeters dilated. This can take up to 20 hours if it's a woman's first pregnancy. It's shorter in multiparous women. The active first stage is from 4 to 6 centimeters dilated until complete 10 centimeter cervical dilation. This lasts about 4 to 6 hours during a woman's first pregnancy. It also is shorter in multiparous women. The second stage of labor is from complete cervical dilation until delivery of the infant. This stage is only a few hours. In nulliparous women, it can be less than 1 hour in multiparous women. And in women who receive epidural anesthesia, that prolongs the second stage of labor. And then finally, the third stage is the period of time from delivery of the infant to delivery of the placenta. Usually this is less than 30 minutes. Shown on this slide is a graph that you can find in many obstetrics textbooks. It shows dilation of the cervix in centimeters along the y-axis and hours along the x-axis. So stage 1 is the longest stage of labor, and the longest phase of stage 1 is the latent phase. That goes until the cervix is dilated 4 to 6 centimeters. The active phase of stage 1 is shorter than the latent phase, and that continues until the cervix is fully dilated at 10 centimeters. Then you have stage 2, which you may know is also called the pushing stage. This is when the woman is pushing the baby out. And then lastly, you have stage 3. Let's talk about the fetal lie and presentation. The fetal lie is the long axis of the fetus compared to the long axis of the mother. The fetal lie can be longitudinal, transverse, or oblique. If you look at the bottom of the screen, this is the long axis of the baby and it's lined up with the long axis of the mother, so this is a longitudinal lie. This baby here has an oblique lie and this baby has a transverse lie. The fetal presentation refers to the part of the fetus overlying the pelvic inlet, and the most common presentation is a longitudinal cephalic presentation, and by cephalic I mean with the head down. That's what's shown in this picture right here. In a breech presentation, the baby is in a longitudinal lie, but the buttocks are the presenting part, and that's what's shown in this image here. The vertex is an area of the fetal head, and a vertex presentation is when the fetal vertex is the presenting part. This is a subtype of cephalic presentation. And this is the ideal presentation for vaginal delivery. So anytime the presenting part is not vertex, that is called malpresentation. So breech is an example of a malpresentation. So is a transverse or oblique lie. So is a presentation where the head is down but the face or brow are the presenting part. Breech presentation is the most common form of malpresentation, and there are a couple of subtypes of breech presentation all shown on this slide. The most common subtype is a frank breech. That's when the rear is the presenting part, but the hips are flexed and the knees are extended so that the feet are in front of the baby's face. In a complete breech, the baby's legs are folded like this, and in a footling breech, one or both feet are the presenting part. And I talk about the management and delivery of babies in breech position in another video. The Leopold maneuvers are 4 palpations of the abdomen of a pregnant woman that you'll be taught how to do on your OBGYN rotations, and they're used to assess the lie and positioning of the baby. They can also be used to estimate the fetal weight, and in fact studies have shown that the Leopold maneuvers are just as accurate as ultrasound at term for predicting the birth weight of the baby. Let's talk about the changes in the cervix that occur during labor. So the cervix dilates during labor. It progresses until it's 10 centimeters dilated, which is fully dilated. But in addition to this, the cervix also undergoes another process called effacement. This refers to thinning of the cervix during labor. So the cervix is normally about 4 centimeters in length, but during labor it effaces, which means it thins, softens, and shortens. So if you look at these drawings on the screen, initially the cervix is closed and it's also relatively long. But as labor progresses, not only does the cervix begin to open up, but it thins, and that's the process of effacement. And then eventually the cervix is fully dilated and effaced. And we refer to effacement as a percentage, so 0% effaced means there's no effacement occurring yet. 100% means the cervix is fully thinned. And some women develop what's known as bloody show. This is blood-tinged mucus that's released vaginally, and this is associated with the onset of cervical effacement. Let's talk about some of the other elements of evaluating women in labor. The fetal station describes an assessment of the leading edge of the presenting part. The fetal station is the number of centimeters of the leading edge of the presenting part of the baby, either above or below the level of the ischial spine. If you look at this drawing on the screen, this is the ischial spine, which is a fetal station of 0. If the presenting part is above that, that's a negative fetal station. If it's below that, that's a positive fetal station. So negative numbers mean the presenting part is inside the uterus, positive mean outside the uterus. And the fetal station ranges from -5 to +5. The higher the number, the closer to +5, the further along the baby is towards delivery. Cervical consistency for a woman in labor can be either firm, medium, or soft. Firm is like your nose, medium is like your lips, and soft is like butter. And ideally you want the cervix to be soft at the time of delivery of the baby. And then lastly, a standard part of evaluating a woman in labor is to describe the positioning of the cervix. It can either be posterior, mid-position, or anterior. Shown on this slide is another fairly classic graph that you can find in obstetrics textbooks. It shows cervical dilation in centimeters on the y-axis, just like the chart we saw a few slides ago. Time is on the x-axis, but on the secondary y-axis we have the fetal station. So the cervix is the dotted line here, and as it becomes more dilated through the stages of labor, the fetal station progresses so that the baby moves out of the uterus and further down in the pelvis. The Bishop score is a clinical tool used to assess the cervix in pregnant women. It's a point system and the maximum score is 13. Shown on this slide is a table from the White Coat Companion with the elements of the Bishop score. So up to 3 points can be given for dilation of the cervix, effacement, and for fetal station. And then 0, 1, or 2 points are given for consistency and position. And based on this, you can get up to a maximum score of 13. The Bishop score was originally developed to determine the likelihood of natural labor. A woman with a high Bishop score was thought to be very likely to enter labor and have a vaginal delivery. In modern clinical practice, it's usually used to predict the success of labor induction. So if you're considering inducing a woman with oxytocin, you want to know what the Bishop score is first. A higher score means the cervix is favorable for vaginal delivery, and there's a higher chance that the vaginal delivery will be successful after induction. A lower Bishop score means the cervix is unfavorable, and there's a high chance that the woman won't progress to a vaginal delivery and will ultimately need a cesarean delivery. There are techniques to ripen or prepare the cervix for labor induction, and I talk about this in the second video on labor and delivery. I'll finish this video by talking about the cardinal movements. The cardinal movements are changes in the fetal position that occur during vaginal delivery for a baby in the vertex presentation, which is the most common presentation. Basically, as the baby is exiting the womb, the head has to move in order to accommodate the bony pelvis. And so there are classic movements called the cardinal movements that the baby goes through in order to be able to fit its way out of the bony pelvis and to exit the womb. The first of the cardinal movements is called engagement. The definition of engagement is when the biparietal diameter of the fetal head descends below the plane of the pelvic inlet. Now the biparietal diameter is the widest portion of the head, and this is said to have entered the pelvis when it descends below the level of the ischial spine. We talked earlier about fetal stations, and the ischial spine is a fetal station of 0. So when the widest portion of the fetal head, the biparietal diameter, is at the level or below the level of the ischial spine, then the head is said to be engaged. And in women who have never delivered a child before, engagement can occur days or even weeks before the onset of labor. In contrast, in women who have had children before, engagement usually occurs right at the onset of labor. After engagement, the next cardinal movement is flexion, where the baby flexes its head and puts its chin to his chest, as shown here, and then the baby descends further into the pelvis. After this, the baby descends further into the pelvis, and it has to internally rotate his head, as shown in the picture here. The baby then completes the rotation of the head, and then it begins to extend its head backwards. And that's what you can see here, where the baby is now beginning to push its head backwards and extend at the neck. The baby then completes the extension of the head as shown here, and then the head is delivered, and as soon as the head is delivered, the baby will externally rotate at the neck. This is a process called restitution. And it's at this point here during restitution when the shoulders sometimes get stuck and a baby can develop shoulder dystocia, which I talk about in another video. And then after restitution, there's delivery of the shoulders. The anterior shoulder is delivered first, followed by the posterior shoulder. And then once the shoulders are out, there's a rapid expulsion of the baby from the womb. And so here's a summary slide of the 7 cardinal movements. It begins with engagement, followed by flexion, descent, internal rotation and extension, then external rotation or restitution, and lastly there is expulsion. And that concludes our first module on labor and delivery.